Hi everyone, I'm Michael Cater. I'm going to be talking about glioblastoma, a review of the old and modern treatment tools that we have. So just a review of the epidemiology. This is, the most common malignant tumor of the brain, an incidence of 3.2 per 100,000 in the population of the United States. Median age of diagnosis is 64, and peak incidence is at 75 to 74 years. Prognosis, as everyone knows, is extremely poor. The 1-year relative survival rate was 41.4% from the years 2000 to 2014. It had improved marginally from 34.4 to 44.6 from 2000 to 2014. Unfortunately, the 5-year survival rate has remained constant and extremely poor at 5.8% of people alive at 5 years post-diagnosis. So how do we get these GBMs? So there's no familial inheritance. There's no known cause of environmental cause for a GBM. What we think happens is the stem cell hypothesis, where we all have stem cells in our subventricular zone that houses neural progenitor cells. These cells are dividing slowly over time to replace glial cells and neurons in the brain. However, as we age, some of these stem cells accumulate gene mutations that lead to tumor characteristics such as invasion, stem cell renewal, evasion of apoptosis. We've proven the presence of stem cells in GBM tumors using single cell sequencing that show that there are stem cells within the population of GBM cells. The main difference in GBM is primary versus secondary GBM. Primary GBM is de novo mutations that lead to as I mentioned before, the common characteristics of cancer. However, in secondary GBM, it's thought that these cancers start off as a low-grade glioma, initially getting hit with an IDH1 mutation, which I'll talk about in a second. But that mutation leads to further mutations causing low-grade glioma, which eventually progresses to a high grade for GBM. So isocytosate dehydrogenase, or IDH mutation, is probably the most studied and most well-known mutation in these GBMs. It's one of the best prognostic indicators in GBM. It's a normal enzyme within the Krebs cycle. It converts isocitrate into alpha-ketoglutarate. However, the mutated form takes alpha-ketoglutarate and forms 2-hydroxyglutarate. And 2-hydroxyglutarate is a competitive inhibitor of enzymes that methylate DNA, which leads to increased methylation of the DNA and therefore epigenetic changes to these tumors, leading to genes that, like I mentioned before, lead to cancer phenotypes. This mutation is more common in younger patients and has been known to show a more favorable prognosis as it responds better to temozolomide. The second most important molecular marker that, in terms of prognosis, is 6-methylguanine DNA methyltransferase, or MGMT, and whether or not the promoter of this enzyme is methylated. This enzyme is a DNA repair enzyme, and is important because TMZ is an alkylating agent that causes methyl group to be attached to the DNA. And normally, this enzyme would then remove that methyl group, and therefore the cell would survive. But in cancer, in GBMs that have the promoter methylated, there's decreased expression of this gene, and therefore the cancer cells are not as equipped to repair the DNA damage for temozolomide, making them sensitive to temozolomide. So everyone who has their GBM resected is tested for this molecular marker in order to determine prognosis for these patients. Other molecular markers that are important but not as nearly as important as the first two: epidermal growth factor as one of the more common mutations in GBM. It's present about 40% of GBM. It's important for tumor proliferation. However, it does not confer any improved prognosis. It's important in that because it's important for tumor proliferation, which I'll talk about a little bit later, it's been a common target for targeted therapy or immunotherapy but I'll discuss that a little bit later in my talk. P53 is the most common mutation. It's the molecule that prevents apoptosis. So mutations prevent these cells from dying with all these mutations in their DNA. It's present in 28% of primary GBM and 65% of secondary GBM. Platelet-derived growth factor is involved in proliferation and stem cell renewal, and phosphatase and tensin homolog, or PTEN, which is lost due to loss of heterozygosity of chromosome 10, which is important for cell migration and proliferation. So this is an important molecule for invasion for GBM. So treatment of GBM, there's the three main pillars: surgical resection, chemotherapy, and radiation. I'll go into each one of those. Surgical resection, obviously the goals of surgery: gross total resection and tissue diagnosis. Tissue diagnosis, for the reasons I mentioned earlier, being looking for IDH1 mutations, MGMT methylation, and also potentially using the tissue for further research and next-gen sequencing to better understand these GBMs. So extent of resection, it was well known for a long time that the more of the tumor you take out, the better the patient does. But it was never quantified as to what percentage of tumor needs to come out in order to confer a survival benefit. In a paper by Sinai in 2011, looked at 500 newly diagnosed GBMs. They measured each person's tumor before and after surgery, and they looked at what percent of resection was needed to confer survival benefit. And you can see there's a stepwise improvement, although marginal at the higher extent of resections, but the more tumor you take out, the better the patient does. And what was surprising is that this survival benefit was seen in an extent of resection as low as 78%. So we know now that you need to at least get 78% of the tumor in order to see any survival benefit from surgery. So how do we, achieve these at as close to 100% of gross total resection as possible? So some of the newer tools of the trade, we have awake craniotomies, 5-ALA, supramaximal resection, and biopsy laser ablation. And I'll go into each one separately. So awake craniotomy, this is important for tumors that are close to eloquent areas of the brain, motor cortex, or Broca's or Wernicke's. The way these procedures are done, we do a circumferential head block using 50-50 bupivacaine and lidocaine. Bupivacaine is a longer lasting agent that allows the patient to remain comfortable during the surgery. They're initially put to sleep and then are awakened for the critical portions of the case. And using an ogimen, for example, in a motor patient, we'll have MEPs. We can see if there's EMG activity when we stimulate the cortex, or whether or not the patient moves their arm or leg. That way we know that this area of the brain is, cannot be resected, and we'll have to leave that. But it allows us to get as close as possible to those areas without causing any harm and decreasing their quality of life in order to resect as much of this tumor as possible. 5-aminolevulinic acid, or 5-ALA. This is a much newer tool that we have now in the United States. It finally got FDA approval. We've been starting to use it extensively here at UMH. The basic science behind it is that 5-ALA is normally taken up by normal tissue, converted to protoporphyrin 9, which is then converted to heme. That's the normal pathway. But in tumor cells, they lack this enzyme ferroketolase, and therefore the protoporphyrin accumulates in these tumor cells. And this molecule can be excited with fluorescence. And this is, normal white light down here, and this is what it looks like under the blue light. This pink area is solid tumor, and as the fluorescence goes down towards, the invasive edge, sometimes you can see fluorescence beyond the area of enhancement, which allows surgeons to feel more comfortable taking out more brain than is beyond the enhancing rim. Obviously, we have to use our best judgment and knowing where we are in the brain instead of just following the fluorescence blindly. And they've shown in Europe that 5-ALA has increased extent for resection and therefore has increased survival. Another study done here looks at supermax resection. So if gross total resection is good, is more better. And the thought process behind this is we see, the bulk of the tumor is the enhancing portion. However, GBM is extremely invasive. A lot of times when patients recur their tumors, it's usually within the tumor bed. And if we had taken out all the tumor, then how are we still seeing recurrence within the tumor bed? So the thought was, if a patient has GBM in a non-eloquent part of the brain, we could do a lobectomy for non-eloquent GBM. So here, Dr. Komatar Ivan and Dr. Shah did a study looking at 69 patients that compared lesionectomy to lobectomy. Overall survival and progression-free survival were increased in the lobectomy group, and greater benefit seen in the IDH mutant and MGMT positive patients. Finally, biopsy laser ablation. This is a tool used, it's a minimally invasive treatment of recurrent and or non-resectable deep lesions, like this one you see in the picture. It disrupts the blood-brain barrier. It allows us to have tissue diagnosis and decrease the tumor burden for deep tumors. Preliminary studies have showed that this is a safe and effective way to debulk these tumors. However, we have yet to show that this is conferring any increased survival or progression-free survival for these deep tumors. But it's still important, like I said before, to get tissue diagnosis in order to choose the correct treatment for these patients based on their molecular profile. So I'm going to touch on the chemotherapy part of treatment. So everyone has seen or read this paper, this radiation therapy plus concomitant and adjuvant temozolomide for glioblastoma, or what we call now the STOOP protocol. This has become the standard of care since 2005. Study took 573 patients, randomized them to temozolomide plus radiation versus radiotherapy alone. The hazard ratio for death in the TMZ group was 0.63, and therefore it's 37% relative risk reduction in the risk of death. There was a median survival benefit of 2.5 months, which, in the grand scheme of things is not a lot, but, every month counts for these patients. So this is the standard of care at the moment. Radiation, briefly, is just fractionated localized radiation. The standard dose of radiation is 60 gray delivered in 30 to 33 fractions to the involved field, as well as 1 to 3 centimeters of margin to try to treat the infiltrating tumor. So why haven't we made much progress in the last 20, 30 years? There are a lot of barriers to treating these tumors. The main one is the blood-brain barrier. We can't get a lot of potential chemotherapeutic agents into the brain because of the blood-brain barrier. These GBMs tumors, it's not one just type of cell. There's a huge range of different cells within the cell population. There's the stem cells, there's various cells that each have their own genetic profile, which makes it hard to treat with one specific chemotherapeutic agent. And again, rapid mutation of the cell population. A lot of times we try to hit the patients with a chemotherapeutic agent, and the GBM changes and becomes resistant pretty quickly to that agent. And in the immune microenvironment of these tumors, where the immune system has a difficulty reaching these tumors, is another barrier to improve outcomes. So currently, how are we trying to avoid these blockades that are preventing us from gaining any treatment benefit of these tumors? So the 3 things that people have been looking at is improved drug delivery to the tumor, immunotherapy, and targeted therapy. So enhanced drug delivery, there are a lot of different things people are looking at. Nanoparticles is kind of one of the new topics that people are looking at. These are easily modulated. You can use many different types of quote unquote nanoparticles. They use liposomes, micelles, metal or polymeric nanoparticles. These can easily bypass the blood-brain barrier and can be easily modified to target the stem cells based on receptors. such as CD155 or others. Unfortunately, this hasn't really been studied in vivo and GBM. They've done in vitro studies that show that these nanocarriers can be taken up by the cancer cells, but it has to be tested in vivo in order to show any benefit. Gliadel wafers. These are wafers that are biodegradable wafers that are placed into the surgical cavity, and they release chemotherapeutic drug of choice over the course of 2 to 3 weeks. This bypasses the systemic toxicity of traditional chemotherapy, since higher doses are required in order to cross the blood-brain barrier. So in a paper by Westphal et al., they put these wafers that contained carmustine, a chemotherapeutic drug, into the surgical cavity to see whether or not there was a survival benefit in patients that had the BCNU wafers containing carmustine. This paper was done on patients with high-grade glioma, wasn't specifically GBM. And the top graph here, there was a benefit to the gliadel wafers in the high-grade glioma group, but in the subgroup analysis of GBM, there wasn't really much of a benefit that was seen. Finally, the main kind of the leading edge of GBM treatment is immunotherapy. There are 4 different ways to attack the GBM cell: vaccination therapy, immune checkpoint blockade, chimeric antigen receptor T cell therapy, and oncolytic viral therapy. And I'll go through each one of those now. So glioma vaccines, basic premise being that taking either tumor lysates or specific markers of GBM and causing dendritic cells to be activated to those peptides. These dendritic cells then activate T cells, which then attack the tumor. So an example of this is rondapiprant. This is a peptide vaccine that mimics and thus targets EGFR, the EGFR mutated version of the receptor. This has been shown to increase overall survival and progression-free survival in a limited study. They looked at these tumors, and when they went in for re-resection of the tumor, they did staining for EGFR, and none of the tumors had continued to express EGFR. So the vaccine itself was successful. However, it was just selecting for tumor cells that didn't no longer express this EGFR. Weirdly enough, the unmethylated MGMT promoter subgroup did better with this glioma vaccine versus those with the methylated MGMT. They think that potentially that this allowed the doctors who were treating the patient to attack the tumor via two-pronged attack with TMZ and with the vaccine, conferring better prognosis. Unfortunately, they started phase 3 clinical trials, which were terminated early due to futility of the trial. They had not reached any of their primary benchmarks, and the study was terminated. Another more promising glioma vaccine uses the patient's own autologous lysate. So the patient has their initial resection. They take the tumor cells, lyse them up, and they pulse the dendritic cells with the tumor lysates. Therefore, these dendritic cells are now being exposed to a wide variety of tumor antigens. It was shown to have some benefit in small phase 1 and 2 clinical trials. They're currently undergoing phase 3 clinical trials, and the preliminary results from that phase 3 trial are actually pretty good. 30% of patients have made it past 30 months of overall survival, which is way beyond what we typically see for these glioblastoma patients. The disadvantages of this is basically it's a very expensive and intensive process to produce a vaccine. The whole thing takes about 30 days. You have, like I said, you have to take the patient's tumor, spin the cells down, pulse the dendritic cells, and then re-inject the patient. So hopefully in the future, there'll be a less expensive and more rapid process to do this, but this is probably the best way to treat gliomas via vaccine, because it's not just using one molecules using multiple molecules from their autologous lysates. Another big part of immunotherapy is oncolytic viral therapy. Here we have viruses that infect the tumor cells, causing lysis of the cells. Dendritic cells again take up these antigens, activate naive T cells, and lead to recognition of tumor cells with these tumor-specific killer T cells. There are currently two promising candidates, DNX 2401 and PVS-RIPO, which I'll go into now. So DNX 2401 is a study done at MD Anderson. This is an adenovirus that has been modified to only replicate in tumor cells that have the mutated retinoblastoma pathway, which is commonly mutated in these GBM cells. They initially looked at this in vitro. They were able to show that it caused direct lysis of the cells. So they did a preliminary trial where they took 37 patients with recurrent GBM and enrolled them into two groups. Group one just had stereotactic tumor injection, and basically at follow-up looked at toxicity and response studies based on MRI. And the second group had stereotactic tumor injection, followed by en bloc resection of the recurrent GBM, and then biological studies and histochemical staining. And you can see in here, these are the re-resected tumors. The arrows are pointing to the injected catheter where the virus was injected, and they looked at basically at different lengths away from the catheter. There was, zone 1 here, necrosis right near the catheter. Zone 2, you can see these are the inclusion bodies from the virus, which are more densely populated here. And then in zone 3, as the virus is making its way out into the periphery, there's fewer inclusion bodies. So amazingly, there was a reduction in size and tumor in the patients, and even some of these patients down here had greater than 95% resolution, which was sustained over a long period of time, which is kind of an incredible result. So they're currently working on phase 3 trials to test whether this is, usable across the board in patients. The second viral therapy, PVS-RIPO. This is a live attenuated poliovirus with a ribosome entry site replaced with that of the human rhinovirus. This way, the virus does not travel throughout the entire nervous system. It reduces the neurovirulence that is typically associated with polio. It uses CD155, which is a common stem cell marker that is highly expressed in GBM. This way, this is how the virus actually targets these tumor cells versus the healthy cells. They looked at 61 patients with recurrent GBM and injected via convection-enhanced delivery with the virus. The mean overall survival was 12 months in the treatment versus the historical cohort of 11.3. These patients met a plateau of continuous survival at about 24 months, and they continue to survive. So they're currently working on phase 3 trials of this virus as well, and hopefully they'll show some benefit. Checkpoint inhibitors, these molecules were very popular recently due to their efficacy in other solid tumors such as melanoma. They've been very successful there. However, their success in GBM has been fairly limited, mainly due to the blood-brain barrier. These molecules have a tough time making it into the brain in order to enact their effect. So CTLA-4, ipilimumab, the basic science behind this is basically the tumor cell has these ligands that will deactivate the activated T cell, so allowing them to evade the immune system and the killer T cells. So these antibodies prevent the binding of these cells, of these ligands to the activated T cell, and therefore the T cell remains activated towards these tumors, and the immune system can kill these tumors themselves. Like I mentioned before, the CTLA-4 ipilimumab toxicity has limited its usefulness in GBM. In order to get any sort of level of the drug into the brain, you have to give very high doses, and patients just don't tolerate it. Nivolumab and pembrolizumab, phase 3 clinical trials of these drugs were ended as it failed to meet the primary endpoint of increased overall survival. The other trials are starting to look at its use in neoadjuvant therapy, but those have also been relatively unsuccessful. Finally, chimeric antigen receptor T cell therapy. This is a newer form of immunotherapy. This takes T cells that are engineered basically to respond to GBM antigens. This bypasses the the long process of dendritic cells taking up these antigens, presenting them to the killer T cells, hoping that the killer T cells then learns and is activated by these antigens and then attacks the tumor. But this is very early on in the studies. IL-13RA2 was just a single case study of a patient with diffuse leptomeningeal disease. It showed about 77% shrinkage of the lesions. And EGFR, again, coming up again, they looked at CAR T cell therapy for this. 10 patients with EGFR positive recurrent GBM, they had infusion. Progression and survival were not affected, but obviously the tumor stopped expressing EGFR because we're selecting for those cells to not survive. Finally, targeted therapy. So advances in next-gen sequencing has allowed us to gain a better understanding of GBM. We know the myriad of pathways that are involved in tumor growth, apoptosis, invasion, and angiogenesis that are being hijacked by these tumors. So all this information is being used to look at new targets. Bevacizumab, or an anti-VEGF antibody. They looked at this in 921 patients that were randomized to standard of care and standard of care plus the antibody. There was a marginal 4.4 month improvement in progression-free survival, but no overall survival. This has been largely used in recurrent GBM now in patients that have a large expression of VEGF in these tumors. But unfortunately, monotherapy has been very unsuccessful. So where do we go from here? There are a lot of barriers to treating these GBMs. I think a lot of what the studies have included is, single pronged attack. We look at, just a vaccine or just the virus or just, one new chemotherapeutic agent. I think it's imperative that we start to try to combine different avenues of attack, either combining multiple chemotherapeutic drugs with immunotherapy. Obviously, some of these initial viral therapies need to be fleshed out a little bit more, but I think there is some hope in that in the next 5 to 10 years we'll start to see some benefit beyond a couple months in these patients. That's it. Any questions?
Great job, Mike. Really thorough. I think the one thing though that you have to mention is the tumor treating fields, just because it is one of the FDA approved treatments for glioblastoma. I don't know if you wanted to comment on that as well.
Not sure. I guess I haven't read up on the tumor treating fields that much.
So, I mean, also, the clinical trial was done by Stoop. It showed that there was increase in survival. Obviously, it's a little bit unclear exactly what is the optimum way of using it, because right now it's something that you start using this. It's kind of stickers that you place on the head. The patient has to keep their head shaved at the time of treatment. You have to wear it for 18 hours a day, hooked up to a battery pack, and then using magnetics. It basically is out. The idea is it tries to prevent the mitosis of cells, or ruin the mitosis of actively dividing cells in the brain, which are mostly going to be the tumor cells. Mm-hmm. So the data shows that it does increase survival. Again, limited increasing, just like the other kind of options, 2 to 3 months or so. And a lot of that is benefit within the first couple months of using it, and so the use of it long term, or the use of it in recurrence, is really not well studied. but it is one of the other FDA-approved treatments for GBM, and so it's important for all of us to know about it.
Yeah, I'll read up more on that.
So as long as everyone can see my screen, good morning, everyone. My name is Victor. I'm one of the PGY2s in this program. Thanks for the opportunity to talk about this topic today. I think we're all familiar with the WHO classification. We use it a lot, especially with tumors in the brain and the spine, WHO grade 1, WHO grade 2. Where does this exactly come from? It comes from this series of the World Health Organization putting together this series of classifications for all these tumors. They do it for CNS. They also do it for all other organ systems of the body. So every so often they update. And the CNS tumor classification is actually as old as 1979. That's when the first one was made. The next iteration was 1993, 2000, 2007, 2016. And now we're at the stage where it's every 5-year iteration. So currently, this is the most updated version, just like the iPhone you can see there. But the question is, what's new? Because typically these tumors remain tumors, but how have they gone about changes? What changes have they made to this year's iteration? And it primarily reflects the increased use of molecular analysis of these tumors as to how we group them, how we categorize them. And the purpose of this talk today is really just to highlight these changes that have been made to this current edition, so that moving forward we can slowly either be aware of them or adopt them in our practice as they become standard. And just like the newest iPhone, we'll start to unpackage it. So like I said, the WHO classification of these tumors, it's a book. You can buy it on Amazon. I don't think this iteration is available in print just yet, but you can buy it on Amazon for $100 or so, and it goes through every single pathology that you can imagine throughout both the brain and the spine. As I previously mentioned as well, there's an increase in use of molecular markers, et cetera, which have really helped shift what we use today. So I want to split this talk up into two general sections. The first is general changes that have been made to all types of tumors within the spine. These include the taxonomy of how we go about, putting these tumors into boxes, the nomenclature we use, a shift towards Arabic numerals, which is very interesting, an emphasis on grading these tumors within types rather than across, the brain and the spine, the continuous use of the not otherwise specified, not elsewhere classified diagnoses, the introduction of integrated diagnoses to help better communicate molecular definitions of these tumors, as well as new entities as well that have been introduced. In addition, after that, there are a number of specific changes that have been made to specific tumor types. The biggest one that I think we're all familiar with, brain and spine, is gliomas. A number of changes have been suggested for that. In particular, the introduction of this term diffuse glioma to cover multiple different diagnoses. There are many other types of tumors, and the ones I want to highlight for this talk are the ependymomas, the medullos, pineal region tumors, meningiomas, nerve tumors, cellular region tumors, and just highlight what has been adapted, what has been recommended by this committee for diagnostic purposes moving forward. So for the first series of general changes, the taxonomy. Now there's no doubt that with the advent of molecular studies that a number of new discoveries have been made, and the challenge really facing the classification is how to organize this by tumor type. Admittedly, there are some tumor types that already have defining molecular features, but there are others that don't. And it's the challenge of this classification system to incorporate what we've known historically by histology for our definition purposes and this new upcoming molecular genetics. And so currently this 2021 edition reflects that we use both, and we use them both almost equally in our definition. And the suspicion is that this only reflects an intermediate stage of where we're going with diagnoses, and that in the future, it may actually be even more precise for that. You can see in this table below a number of different tumor types and their well-known associated molecular profiles that have been established over the last 5 years, and how this current classification expects these to be incorporated into diagnostic definitions. What's interesting also, on a more technical note, is that they're encouraging the use of the term type rather than entity, and subtype rather than variant, to help be more consistent throughout both this classification system within the CNS as well as all the other non-CNS tumors. The shift in nomenclature reflects a more updated committee agreement to be more consistent and simple in how we diagnose these tumors. In the past, some tumors have had anatomic site modifiers, such as the chordoiglioma of the third ventricle, where others did not, despite occurring in specific locations like medulloblastomas. Other nomenclature includes genetic modifiers such as glioblastoma, IDH wild type, where others did not, despite having specific genotypes such as ATRT. Therefore, these names, they're encouraging to be as simple as possible and to utilize location, age, and genetic modifiers only when there is clinical utility in either discussion, planning, or management, such as neurocytomas, and whether they be extraventricular or central. One of the biggest changes that would probably be most practical for us today is the use of the encouragement of Arabic numerals for WHO grading. Up until the 2016 edition, the CNS tumors have typically used Roman numerals. And you may yourself have you had to double look and see if something was a grade 2 versus a grade 3, or grade 3 versus grade 4. And what's interesting to note, in all other non-CNS tumor classification, they've all adopted Arabic numerals, and it's only us in the CNS that have persisted with Roman numerals up until this current edition. So this current edition, the WHO makes a very clear statement saying that they defer now to Arabic numerals, and I actually think this is going to make things a lot easier, and it's going to make things less confusing when trying to communicate those Roman numerals that look very similar to each other. And so in this table below, you can see some more prototypical examples: astrocytomas, grade 2, 3, 4, as well as oligos and glioblastomas as well, with their associated grade 4. And it's something that we could insert using our practice today, the use of Arabic numerals for all gliomas that we see. Another interesting change that they're encouraging is to grade within types of tumors. And probably most practically, they're dropping the term anaplastic. And it's really a reflection of tumor-specific biology. An anaplastic meningioma and an anaplastic ependymoma, whilst they have similar features in terms of the histology, don't clinically always behave the same. And the shift away from using terms such as anaplastic is to avoid trying to compare apples with oranges in terms of tumor types. As a result, being able to do this, instead of saying anaplastic, it would be ependymoma grade 3, meningioma grade 3, or grade 2, is that it provides more flexibility to use grading relative to the specific tumor type, and allows us to emphasize the biological similarities within that tumor group, meningioma with meningioma, apples with apples, rather than try to approximate it across different sort of tumor types. And similarly, this is also practice adapted in the non-CNS tumor types as well. So it in some ways bringing us all together closer with the other tumor types to be more specific there. One thing that this classification system did want to make clear is that they will continue to use the NOS and NEC diagnoses when applicable, and stands for not otherwise specified and not elsewhere classified. And these represent tumors that still need or require diagnoses based on more information that may not be available at the time. Specifically, NOS indicates the diagnostic information necessary to assign a particular diagnosis is not available, whereas NEC is that they have been, all the data is there, but they do not allow for a specific WHO diagnosis at the time. The NEC diagnosis is what pathologists continue to use as a descriptive diagnosis, and provides an alert to oncologists, clinicians, our surgeons, that the tumor doesn't conform to a standard WHO diagnosis, and as a result can be worked up separately, sent for more consideration. And that leads on to the next point of an integrated diagnosis. An integrated diagnosis is a common term used in the other classification systems that reflect the growing molecular data, and that there are many ways to describe the same tumor. And in order to be more consistent across both within a department, within a hospital, and indeed within a network, is to try to be able to provide data that can be that cannot be misinterpreted, no matter where it's read. And as such, it involves both the histology, the molecular, and other key types of information, which can also reflect the NEC and NOS diagnosis as well. So here are some examples of what we're talking about with an integrated diagnosis, and it's a histological diagnosis with the WHO grade and molecular information when possible. And so some examples include what we have here below. For example, looking at this epidemiology diagnosis, the integrated diagnosis would be supratentorial, epidemiology not otherwise specified, but the histopathological classification is epidemiology, the WHO grade is 3. And then you can see where the NOS diagnosis comes from. It's from the insufficient data from the molecular information available at that time. Compare this to another type of integrated diagnosis here. You can see that this is a diffuse low grade, and the subtype would be this specific molecular marker. And the histopathology, however, still remains oligo, with a WHO grade not assigned in this setting. Nonetheless, there is molecular information which can help subtype the tumor. What's always exciting with these new sort of diagnoses and new sort of classifications is to see what new boys and girls are on the block, and to see what have been introduced. This two classification here introduces 22 new entities, new players into the diagnostic field. There are 14 new molecularly defined diagnoses. 5 of them have been defined as diffuse tumors. This is definitely more of a reclassification, but nonetheless remains a new entity in this setting compared to the 2016 iteration. There are 3 provisional diagnoses or entities that have been provided in this that require further confirmation. Three of these are pediatric conditions, and 1 of these is a spinal condition. There are multiple other diagnosis entities that have been considered in this current iteration that have not been accepted as an entity just yet, given the lack of homogeneous data. But nonetheless, I'm sure in the next iteration, there'll be another set of new people on the block for further workup. So just quickly here in this table, you can see all the new all the new tumor types that have been introduced. Highlighting here are the new diffuse glioma diagnoses. You can see they actually represent different types of astrocytomas and what we've previously known as midline gliomas that have now been reclassified in this setting as high-grade gliomas, different specific molecular markers as well. Here are the 3 new pediatric diagnoses that have been introduced. Most interestingly, draw your attention to the infantile hemispheric glioma. One thing that they're shifting away from in the infantile demographic is the use of glioblastoma. Typically something that was histologically seen as glioblastoma was referred to as glioblastoma of the young, but data is emerging that this is not the case. And as a result, the CNS is actually taking away preference in using the word glioblastoma in this setting. Here you can see the next highlighted are 3 provisional diagnoses. These are ones that require further clinical affirmation as to the clinical course, but nonetheless have been recognized as most likely to be diagnostic and separate. And finally, the spinal ependymoma with MYC and amplification is the newest spinal tumor that has been recognized as a separate tumor type. So that there is a brief rundown over the general changes used in the latest iteration. And now I'd like to just spend some time looking at the specific changes that have been approached for those specific tumors. The first one is gliomas. This has undergone a new revision in how it's classified, primarily based on the overwhelming molecular data that's coming out and the response to treatment, as Kata alluded to. The first differentiation, or the first fork in the road now that they use, is adult type versus pediatric type. They use this primarily to help sort of differentiate those that occur more in adults with those that occur more in kids. And the majority of the adult type diffuse gliomas incorporate what we typically know already, glioblastomas of multiple different grades. Within the pediatric type, they've now started to classify these within low and high grade, given the difference in prognoses that they've seen clinically. So as I quickly mentioned, the adult versus pediatric type glioma, it's just a new take on how we classify what typically occurs in what age group. The CNS, the WHO group typically use the word primarily for what tumor primarily occurs in adults, what tumor primarily occurs in pediatric groups. And this allows for a flexible crossover in terms of when to expect what, especially in the young adult population, which can sometimes show these pediatric types, and also in the older kid generation, which can also show adult types of tumors. It's really designed to improve prognostication and allow for our further update into research as we move forward. Now, within the adult type diffuse gliomas, they've really changed this to help make it more simple in terms of accommodating all these new molecular data. In the previous classification, you may be more familiar with diffuse astrocytomas, anaplastic astrocytomas, glioblastomas. And one of the biggest changes now in the system is the IDH mutation status. That is becoming very diagnostic of a pathway within the adult type system for which way these gliomas can be classified. The first dot point shows when they're classified as mutant. They're considered a single type astrocytoma, IDH mutant, and then graded according to the WHO grades. Now, in this setting, glioblastoma would be the equivalent of astrocytoma IDH mutant, grade 4. For those that are IDH wild type astrocytomas, the presence of one or more of these three genetic parameters indicate the highest grade, whether that's TERT, EGFR, or the chromosome 7, chromosome 10 combination. This, if there's a presence of one of these, this itself is also known as glioblastoma as well. So the take-home point from this slide really is that IDH mutation status is becoming a key classification fork in dealing with these adult type diffuse gliomas. And this occurs both within the brain and the spine in terms of how they go about differentiating this. For the pediatric diffuse gliomas, as previously mentioned, glioblastoma is a term no longer utilized in this setting. It's primarily high grade. We had a pathology talk last week about a H3K27M mutation that was typically found in what used to be known prototypically as diffuse intrinsic pontine glioma. This actually was slowly revised in the 2016 edition to become diffuse midline glioma. And now in this edition, we're now recognizing it as H3K27 altered to reflect the multiple different subtypes of H3K27 alterations, with the K27M substitution being the most common, but a number of other mutations as well. Again, this is most common in the pediatric population, but again, there's evidence of these sort of altered mutations in adults, especially within the spine. And so it reflects that whilst it's pediatric type, can occur in others, other demographics, other classifications. And it's not necessarily K27M anymore, but more so altered given the number of subtypes that have been established in this demographic. If we shift gears a little and now we look at ependymomas, the ependymomas have always typically been classified based on anatomy, the supratentorial, posterior fossa, as well as the spine. This current definition now incorporates both molecular features as well to these anatomic sites to leave this combination. So this new setting actually introduces now two new molecularly defined types within the supratentorial, the ZFTA and YAP1. The ZFTA is a new designation of what's previously known as the RELA fusion pathway, because the ZFTA may actually be fused with more partners than the RELA itself. Within the posterior fossa ependymomas, group PFA and PFB persist. And within the spinal tumor, there's the presence of the MYCN amplification, which is now being used as a new molecular alteration to look for in these tumors. Other slight tweaks that they've made to this tumor group include that MixoPAP is now considered WHO grade 2 rather than WHO grade 1. Since its likelihood for recurrence is now understood to be more similar to conventional spinal ependymomas. Also of note, which I haven't listed here, is papillary, clear cell, and tannicytic morphologic variants are no longer considered ependymomas, but rather now incorporated in the description of ependymomas themselves. Finally, similarly to what we've said before, is The term anaplastic has been dropped. Now, typically we've referenced the word, the term anaplastic ependymoma before, but now it's no longer listed in this new classification. The pathologist can still classify these ependymomas as grade 2 or grade 3, according to its histopathologic features as well. When we look at the next group is medulloblastomas. The current classification has altered it slightly to incorporate more biologic data, but nonetheless, the principal 4 groups, Wnt, sonic, hedgehog, group 3 and group 4 persist. It's just now we have more subgroups than ever before. The sonic hedgehog group now has 4 new subgroups, and there are 8 subgroups now in the other remaining groups. And this has all been established through large-scale methylation and transcriptome profiling. And given, however, of all the tumor types that are listed here, the classification recognizes medulloblastoma as probably the most heterogeneous in terms of trying to combine multiple histopathologic and molecular markers as well as clinical outcomes, which, as we know, can differ even within the group prior to this introduction of these molecular groups. And so the medulloblastoma diagnosis is perceived to continue to require further definition in the upcoming diagnoses, as well as the encouragement to use both the integrated format as we previously described. In addition to that, to also use the not otherwise specified, not otherwise clarified, not elsewhere classified designations as well. The next group to consider are the pineal tumor groups. What they recognize first is that the histology grading for the intermediate grades still remains a work in progress. The pineal parenchymal tumors of intermediate differentiation is one of those examples, as well as the other papillary tumors of pineal regions. Various molecular markers are slowly being discovered to help prognosticate these specific intermediate grades. KBT, BD4 in frame insertions is one of them that has been recognized, but nonetheless, the pineal tumors remains a group that is still being defined better and better, from pineocytomas to pineoblastomas. They've incorporated a new diagnosis here, the desmoid myxoid tumors with this specific mutation. And however, they've resisted the temptation to further define other diagnoses of the pineal region just yet, waiting for more data. Nonetheless, with the increase in methylation profiling, the pineoblastoma subgroup itself has then been divided into 4 new groups based on molecular markers. Just briefly, the altered 1 is more common in children, characterized by the DICER1 mutation. The altered 2 is more common in older children with a better prognosis. And the MYC FOXR2 is more common in infants, and the pineoblastoma B1 altered behaves more similarly to retinoblastoma. The next group to consider are the meningiomas. Now, meningiomas will continue to remain one single type within this current classification with multiple subtypes up to 15. We're now emphasizing more the use of grade 2, grade 3, rather than the use of atypical or anaplastic. And whilst there is a number of genetic markers being considered, none of this is official. And as such, we'll continue to then use the histologic grading as well for these. Of specific note for us could be that chordoid and clear cell meningioma noted to have a higher likelihood of recurrence and have hence been assigned prototypical grade 2 rather than grade 1 as in previous definitions. You can see of the many subtypes of meningiomas that many are starting to have defining genetic alterations, which in the future we perceive to most likely be incorporated moving forward. There are several molecular markers being associated with the grading and prognostication of meningiomas, which as we move forward in our practice, I'm sure we'll see more and more of in the pathology reports, which may or may not be able to help us further change our practice. Of note, BAP1 is more common in specific subtypes as the K-alpha-R mutations. The TERT promoter mutation is becoming more prevalent within meningiomas as well as other diagnostic tumors, as well as the CDKN2A. And these typically now, as you saw in the case in the setting of gliomas, similar in meningioma, considered high grade. However, in this case, grade 3 rather than grade 4 of the gliomas. H3K27 trimethylation loss is linked with potentially worse prognosis, including increased recurrence. However, the jury still remains trying to define exactly how that works. And methylome profiling, as mentioned in our previous guest lecture talk, is also starting to be incorporated into institutional level classification, which may assist further in the prognostication. I have no doubt that in the next iteration that methylome data, as well as a number of these other markers, will be incorporated into defining what meningiomas are. Shifting gears to nerve tumors now, there are several classifications have been changes have been made to nerve tumors, and this likely reflects our increased use in understanding of what these nerve tumors are. One pragmatic change has been the paragangliomas have been now classified as nerve tumors given their involvement of neuroendocrine cells within the sympathetic and parasympathetic systems. And so in the current setting will now be considered as nerve tumors moving forward. A couple of technical changes have been made. What's previously known as melanotic schwannomas have been renamed malignant melanotic nerve sheath tumors. This reflects the distinctive aggressive type and genetic profiling that differentiates this from other nerve sheath tumors, and in accordance with soft tissue classification, tumors has been given this term. A new subtype, there's always new subtypes in this nerve tumor group. This new subtype has been called atypical neurofibromatosis neoplasia of unknown biological potential. Most likely reflects our increased understanding of these intermediate grades of these tumors that haven't been seen before, and this is typically associated with NF1, but is not sufficient enough to be called MPNST just yet. So again, ANUBP. There's got to be a better way of saying that, and but nonetheless, a new diagnosis there as well. Finally, when it comes to the cellular region tumors, these craniopharyngioma subtypes were previously considered variants of craniopharyngioma, but in this new definition have been given a new, their own distinct tumor type moving forward. And there's a new term, a pituitary neuroendocrine tumor, which is being proposed by the endocrine tumor group, which the CNS tumor group is now tentatively acknowledged, but requires further discussion with the endocrine committee to further truly define how this specific tumor differentiates itself from the other cellular region tumors that we know of, and is something to look out for. Finally, one new diagnosis that has been introduced within the pituitary group is a pituitary blastoma. It has it's a rare embryonal neoplasm of infancy that is a mixture of all these different types of cells that has been added as well. So you can see that this classification system is not afraid to continue to add new diagnoses, and as we continue to move forward, I'm sure with molecular markers there'll be more and more tumors within the cellular region and elsewhere that are defined furthermore by these new molecular markers. So in summary, there are a number of general changes that have been made to tumors of the brain and spine, the taxonomy, the nomenclature, the shift towards Arabic numerals, the encouragement to grade within types, the persistent use of NOS, NEC, integrated diagnoses and new entities, as well as a number of specific changes, the greatest glioma, the use of conceptualizing diffuse glioma and grading within that based on molecular markers, the ependymomas, medullos, pineal region tumors, meningiomas, nerve tumors, and cellular region tumors. The current classification system is currently in its wholesome, not available for public reading just yet. These are all previews of what is to be published by the WHO group, but nonetheless, you can keep or watch out for this space, and when it does come out, read through it in its entirety. It covers all the different types of tumor types, but these reflect the latest changes. And I guess to the next question is where to next. Going along the line of the iPhone always evolving, you can see I have no doubt that the classification of CNS tumors is also going to continue to evolve. In 2017, there was only one camera for the iPhone, and I think in the latest iteration there's going to be 3 or 4. And I have no doubt as the iPhone continues to evolve, they'll have many more cameras, to the point you can see in this image, and they'll continue to evolve. And I guess the question is for CNS tumors of the brain and spine, how that will evolve. Obviously, molecular markers are going to have a big role in defining these tumors, but what else could there be? And could there even in fact start to be a division, because there's just so many molecular markers out there that it becomes to the point where individualized medicine takes over and individualized diagnoses then dominate to the point where it's very difficult to generalize across different tumor types. The next iteration is tentatively scheduled for 2026 when the new committee meets, and it'll be great to see what they bring to the table there. But otherwise, that is a brief summary of the latest changes to the WHO classification of CNS tumors for the edition in 2021. Thank you.
A great summary, Victor. Thank you for doing that. It's really important to know what the changes are, because it not only affects what we see in the pathology reports, but also when we talk about retrospective reviews, clinical trial outcomes, and how we look at all of recording of any data. It's important to establish what diagnosis was used and when that diagnosis was used from. So as you're saying, that GBM in 2010 is going to be a different characterized tumor than it is now in 2026. So that's key. One question I had was, I know you talked briefly about methylation. I want to know if there's any other new kind of molecular characteristics like epigenetics that you saw in any of the tumor types, and then specifically for the medulloblastoma, when you did talk about some methylation, were they actually using that in the WHO classification, or was that just something to come with the methylation of the medullas?
Yeah. So the classification, Dr. Ivan, thanks for asking the question, encourages and recognizes the use of methylation as part of its diagnostic armamentarium. I think the issue and the reservation they have from incorporating it officially into multiple other diagnoses is its availability. I think they recognize that methylation profiling is not readily available to the grand scheme of things as it stands right now. So I think I wouldn't be surprised in the next iteration if they do incorporate it. Looking through the other tumor types, meningiomas and gliomas specifically, they do also mention methylation as well. However, I think they've stopped short of incorporating it officially into their diagnoses. Specifically within the medulloblastoma subtypes, those have been recognized officially as subtypes of medullo using the methylation profiling. But it's interesting to see because a lot of those occur in pediatric infantile diagnoses. So how commonly they can be used, I think, is yet to be seen. But at least within that medullo subgroup, they have been recognized as a subtype.
Hey, Victor, great job. I was just wondering, and you may have mentioned it early on, but is the drive for these changes coming from neuropathologists, neurologists, neurosurgeons, basic scientists? I mean, just not being in the field, I find it much more confusing now than it was before. Maybe just because I'm used to the old scheme, but there's a lot of changes. It's like totally different. So I was just wondering, where is the drive for making these changes coming from?
Yeah, thanks, Dr. Levy, for asking that question. My suspicion and the primary authors of this classification remain neuropathologists. They really drive the classification, the building of this. And there's also another group. It's called the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, See Impact Now, which you may have heard of as well. And they're also driven by a group of primarily neuropathologists that make recommendations, who then accept their own recommendations when they create this new classification. And I think that's it. I think there's a drive from their end to help try to diagnose more and more molecularly. And when they find a new molecular marker, ever since the advent of these molecular studies, try to see best and make sense of how this incorporates itself into our current framework of definitions. It may be a byproduct of our own curiosity in some ways. As technology advances and we can ask more questions, I guess we have to figure out what we do with those answers. And I suspect it actually could be a reflection of that too.
Victor, this is Dr. Harris. Maybe I missed it in the talk, but what is the time? When do they intend to make these official and start reporting the pathology results with this new nomenclature?
Yes, Dr. Hiros. They've introduced it now. It's the 2021 iteration, and I think they're encouraging its use from this point onwards. I think it's probably user dependent how comfortable a pathologist or a clinician feels utilizing it. But these are definitely the most updated recommendations from a couple months ago.
Yeah, in speaking to Hume during the last meeting, we've asked him to kind of set a date. He started integrating some of these into the diagnosis so far, but we've asked him to like set an official date here at when we're completely onto the new paradigm for the new classification, and he hasn't let us know what the date is yet, so it's to be determined.
Do you think this is helpful, Michael?
I do. I mean, I think it's important to understand the subtypes. And I mean, when you're trying to discover a new therapy for a drug, and you look at the survival curves, and then you see, okay, there's 10% of the tumors that are people dying early, and then it's a question of like, well, why is that happening? Is it because the treatment's not working, or is it because that 10% is a subtype of a subtype that we know is worse off? And so by understanding more details, you'll kind of understand a little bit better when we come out with new therapies. Are they working for the patients we expect them to work for, or are they working for the subtypes, or exactly how we could target them for these more complex tumors like medulla and glioblastoma and whatnot? So I think it's going to be important.
Good.